Okay, everybody, I think we're ready to get started. Looks like we've got 29 people joining virtually. Welcome and thank you for joining. This is the open committee of the Melanoma, SWOG Melanoma Committee. So welcome everybody. We're starting off today with the keynote speaker that I think is so relevant in these days of new drugs. In these days of new drugs getting approved, one of the things that impacts patients often is just how to deliver that care. How do they get this in the real world and maintain their finances, their sense of normalcy? So it's my pleasure to welcome Dr. Veena Shankaran. She's a local from the University of Washington, Fred Hutchinson, and she's co-director of HICOR, the Hutchinson Institute for Cancer Outcomes Research, where her research focuses on exactly this question. What is the impact of the care we're trying to deliver to patients and their caregivers' finances? So welcome, Dr. Shankaran. Thank you so much for giving us your time today. She will have to go out a little bit after her talk. So if there's any questions, please put it in the chat. I'll try to man the chat and then we can fire away after you're done. And I think the only thing he was saying is maybe point the advancer that way. Okay, that's where the base is.
Well, thank you so much. I want to thank Dr. Patel for inviting me to talk with you. I'm delighted to be here to talk to you about this topic, which is really, I've sort of spent the last 12, 13 years or so really thinking about and trying to conduct studies within and outside of SWOG to really sort of understand this problem in a more holistic way. I know that some of you were at the plenary session just before this meeting, and so you probably got a little bit of a teaser of some of the stuff I'm going to talk about. Dr. Hirschman, I think, shared some of our data. I'm going to try and dig a little bit deeper into some of the studies, but still try and keep this sort of high level and conceptual. Happy to chat with anyone later on if you want to get more detailed into study design and methodology and those kinds of things. And I guess I'll just start off by saying that I think this is a great opportunity for us to sort of collaborate more between committees. I spend most of my time at SWOG in the Cancer Care Delivery Committee. Let's see if this, sorry, where did you say I need to point it?
Yeah, he's sitting with the... not sure if the clicker is working from back here.
I keep clicking it. It's not.
For those virtually, this is an intentional blue screen at the moment.
Okay, there we go. Let me just make sure that this, okay, there we go. As I was saying, I spend most of my time within SWOG in the Cancer Care Delivery Committee. And I thought I would just first describe what cancer care delivery research is for those of you who are sort of new to this concept or not familiar with it. Cancer care delivery research is an emerging multidisciplinary field that really studies how social factors, financing systems, organizational structures, and technology, and also behaviors, both provider and patient behaviors, affect many aspects of care, including access to cancer care, quality and cost of care, and ultimately the health and well-being of cancer patients and survivors. The two key principles of cancer care delivery research, unlike, for example, implementation science, which is also an emerging field, the cancer care delivery research is really defined by the generation of new knowledge to inform practice change. And importantly, it should be conducted in diverse practice settings. So actually the NCORP is the ideal setting in which to conduct cancer care delivery research.
Uh-oh.
Well, hopefully we can go backwards, but I can't seem to go forwards. Okay, there we go. And so one of the reasons that cancer care delivery research is so important is that the healthcare delivery system is so complex, and it's becoming increasingly complex. And so really a lot of factors beyond just treatment and drugs can affect how patients receive care, who gets access to care, and outcomes. And one of the things that I've been really compelled by is, aside from just how complex the medical industrial complex is, are issues around insurance, the complexity of navigating healthcare insurance, the fact that there is very little transparency about costs in the healthcare system, and in particular, as it relates to cancer patients, just the rising overall cost of care and the structure of insurance that really is unfortunately not favorable to people with high cost diseases like cancer. And so really that has sort of led me down the pathway of trying to understand financial hardship or financial toxicity more. And I will say that it's been really wonderful that SWOG has sort of taken the lead in trying to conduct studies, national studies, to really understand this problem. And SWOG was actually the first cooperative group that led a study on financial toxicity, and we'll talk about it in a minute. But since then, other cooperative groups have developed studies in other diseases to really try and get a more nuanced understanding. So it's been really nice to see that over the last few years. So in terms of my objectives today, first I'll talk about what financial hardship is, sort of define this concept and discuss, why it matters. What are the downstream effects? I'll focus a little bit on the SWOG studies that we're doing to understand financial toxicity better, but also include some recent findings from studies that we've conducted outside of SWOG. And really, lastly, and most importantly, I think, focus on what we as an oncology community can really do to address this problem. And in that context, I'm going to be talking about a study, the credit study, or S1912CD, that we just opened about 6 months ago. Before I do that, though, I'm going to just kind of share some basic information to sort of set the stage for this discussion today. A lot of these slides, this is stuff you guys already know, but sometimes it's really impactful to see this, in visually. We all know, I think, that the U.S. spends far more than most developed comparable countries on healthcare, and the vast majority of the spending is on inpatient, outpatient care and prescription drugs. And I think one of the questions we need to ask ourselves is, does this increase in spending, that the healthcare spending by the US, result in improvements in a variety of outcomes? First, do we have quicker access to newer therapies? I would say yes, that's probably true. We do that. The United States FDA does approve more drugs and more quickly than the US and Canada, and we can argue whether or not that's a good thing. But there is quicker access to therapies. Do we have greater and more equitable access to health and cancer care in the United States? I mean, I would argue we probably don't compared to many comparable developed countries, in the sense that we still have 31 million people in the United States that are uninsured in spite of the Affordable Care Act. And we are well aware that folks who are lower income, from underrepresented minorities and socioeconomically disadvantaged, have a greater risk for being uninsured. And then the question is, do we provide better cancer care quality? And do we have better outcomes, such as survival? And I think it's really unclear if we do. We've done a couple of studies comparing cancer care delivery and outcomes in the United States versus Canada. And what we found is that in the case of colorectal cancer, we spend twice as much, but survival and the proportion of people who receive treatment is essentially the same. And we've also seen that at the end of life, we have a lot more healthcare utilization in the US than in Canada. I would argue that both of those things are not good. In the context of what we spend, I think it's really critical to understand, sort of the consequences. Cancer is, in particular, an important area of healthcare spending, and actually about a third of new approved drugs in the United States are cancer drugs. So this is really a kind of growing area of drug development and US healthcare spending. So we know that launch prices and post-launch prices are increasing faster than inflation. And the prices of cancer drugs are not necessarily correlated with clinical benefit. Another issue with cancer drugs is that often these are given in combination, and patients are often receiving therapies over longer periods of time as survival has improved, which isn't a bad thing necessarily that people are living longer. That's a wonderful thing, but the cost implications are there. And finally, with the emergence of potentially less toxic therapies, and you can argue whether they're really less toxic, but immunotherapies, which are perceived as low toxicity drugs, can often be given in scenarios where the benefit is marginal in people with poor performance status or Hail Mary situations towards the end of life. And we recently did a study looking at utilization of immune checkpoint inhibitors versus systemic therapy, other systemic therapies within the last 30 days of life. And what we found is that over time, the use of immune checkpoint inhibitors in the last 30 days has increased significantly. And this is likely to increase more as more drugs come out. In terms of immunotherapy, and I'm not picking on immunotherapy, but this is the melanoma group, so I thought I'd talk a little bit about it. But immune therapy drugs are a growing area of cancer drug spending, and it's projected by IQVIA that by 2025, approximately $56 billion will be spent on immuno-oncology agents alone. So what is the upshot of all of this that I'm telling you, that US healthcare costs are rising, that cancer drug prices are rising? As we've seen these trends in increased healthcare costs, we've also seen a trend towards rising cost sharing for patients. So those are data from the Kaiser Family Foundation that showed that over time, and this graph stops at 2015, but the trends continue in the same trajectory. Premiums for employer-based health plans, as well as coinsurance, deductibles, and copays have increased significantly over time. And importantly, we've seen a sharp uptick in multi-tiered drug formularies. And this is relevant to our patients because a lot of new therapies in cancer are oral. And so oral drugs are often go through the prescription benefit rather than the medical benefit, and are often associated with very high coinsurance. So this is obviously an issue for our patients in particular. Added to all of this, sort of in the background of this, is that Americans are financially fragile. This is a survey asking Americans, how would you deal with an unexpected expense, such as an emergency room visit or a car repair that could cost $1,000? And less than 40% of Americans could say that they could actually come up with that kind of money to finance that sudden expense. So this is, it's the case that Americans have very little money to spend. And there have been some changes that have perhaps mitigated the unfettered out-of-pocket spending, such as out-of-pocket cost limits from the Affordable Care Act. But in 2022, the annual out-of-pocket limits under ACA are significant. So for an individual, that's up to $8,700, and for a family, $17,400. And though this is not paid as a lump sum at one point in time, usually, as most of us see in our clinical practices, cancer patients usually reach their deductibles and potentially their out-of-pocket limits more quickly. So all of this brings me to the concept at hand, which is financial hardship or toxicity. And there has been an increased recognition of the fact that this is a really multidimensional concept. And Reggie Tucker-Seeley and Robin Yabroff have created this conceptual model to help us understand the problem of financial hardship. And they characterize three different aspects of this issue. One is the material financial hardship that consists of the things that you might classically think of as high out-of-pocket costs, debt, loans, defaults, overdue credit card payments, collections, etc. We have the behavioral aspects, such as non-adherence with medications due to cost issues, avoiding care due to cost issues. And then we have the psychological components, which may or may not necessarily correlate with these other two domains, but this constitutes fear about how cancer is going to affect the patient's finances or the finances of their family or the legacy of their financial legacy of their children. We know that there are certain factors that increase risk of financial toxicity or financial hardship. Younger age has consistently across studies been shown to be associated with a higher risk of financial hardship. Lower income patients are at higher risk, not surprisingly. Women, underserved minorities, and cancer severity. So people who are getting therapies for longer, combination therapies, tend to have more risk for financial hardship. And a body of literature has really started to look at what are the consequences of financial hardship on patients and outcomes. And there's data now suggesting that financial hardship leads to decrements in quality of life, which should not be very surprising, that it increases caregiver burden, that because of that potentially increases ER and hospital use, and also decreases survival. There was a study that we did that many years ago now, but we showed that people in Washington state who filed for bankruptcy versus cancer patients who did not file for bankruptcy had a significantly higher risk of cancer death. But importantly, and I know I talked a lot about cancer drugs just a few moments ago, but this problem of financial hardship is not solely just a problem of high-cost drugs. This is a really multidimensional problem. There's other medical costs, and in fact, costs related to hospitalization and medical equipment, supplies, et cetera. There's non-medical costs related to transportation, housing, and the indirect costs related to lost employment and income for both the patient and potentially the caregiver, and really kind of a change in the career trajectory one might have hoped for, including missed raises and promotions. And there's an abundance of literature now really showing the impacts of cancer on employment and income. So when we think about financial hardship, and much of the prior literature has shown that about 40% or so of cancer patients experience financial hardship. Well, estimates range anywhere from 20 to 40%. That had been our understanding for a long time. But the limitations of many of the prior studies that have been done are many. And the first is that most have been done retrospectively. And so there's obviously an issue around recall bias there. They've not been longitudinal. They've focused largely on long-term cancer survivors who are potentially many years out from cancer diagnosis. And there's really limited information about the caregiver or household financial impact. And so with that as a background, we, within the Cancer Care Delivery Committee, conducted a prospective observational longitudinal study addressing or assessing financial hardship in patients with metastatic colorectal cancer called S1417CD. And our goal of this study was to really try and estimate the incidence, the cumulative incidence of financial hardship in colorectal cancer patients. Again, focusing on the advanced cancer population. The study setting was the NCORP. So this is a really wonderful infrastructure for conducting cancer care delivery research, in that it's representative of over 1,000 community-based clinics throughout the country, including minority and underserved clinics. And here was our basic schema for the study. So we enrolled patients within 120 days of diagnosis of metastatic colorectal cancer and around an initial window of time around their first dose of systemic therapy. We included only people who were getting some form of systemic therapy so that we could really capture the costs associated with treatment. But you could argue that not people who get treatment are not the only ones who face financial hardship. We asked patients and caregivers who enrolled to complete surveys at baseline, 3 months, 6 months, 9 months, and 12 months, so essentially every 3 months. And then we pulled credit reports on patients at baseline at 6 months and 12 months. And the reason we did this was really to get both a subjective sense of their financial burden through the surveys, but also to get objective measures of financial hardship from credit data. And I'll talk about that in a little bit. The primary objective, though, of the study was really to estimate the cumulative incidence of self-reported major financial hardship at 12 months from enrollment. And we defined this as new accumulation of debt, selling or refinancing one's home, a 20% or greater decline in income, or borrowing money or taking out loans to pay for cancer treatment. We have a number of secondary objectives, which I'm not going to talk about in detail here, but we plan, and many of these are ongoing, but we're just looking at risk factors for financial hardship, looking at the association between financial hardship and quality of life, determining really the feasibility of surveying and recruiting primary caregivers to understand their financial experiences, and also correlating self-reported measures with the credit report data, as I mentioned. So this slide here is really for the early investigators in the audience, because I just wanted to show you that, especially since this study was kind of different and novel within SWOG, how long it took to get the study from approval to activation. And I didn't even list here when I got the first grant to do this, which was back in 2012. So this was a long, long process. And this is okay. It was hard in the moment, and while it was happening, there were a lot of things to juggle, but eventually it worked out. And I just want to emphasize that that this is not any unique experience necessarily to me, but it just takes persistence and a willingness to work within the system, and I think eventually, good ideas will come to fruition. But in this particular case, and I would say this is probably longer than other studies, because there was a lot of creativity required by all parties to figure out how to obtain consumer credit reports. And we worked with a company called TransUnion to do this. We had never had a process of linking credit reports with prospective patient data. There was a long legal review and contracting process with SWOG. We had to collect Social Security numbers from patients, and this is not a standard data element collected in studies, SWOG studies. There were obviously some privacy concerns raised by participants. And lastly, we had to work on assuring study subjects that obtaining credit reports for research would not affect their credit scores. So there were a lot of things that we had to sort out in order to activate the study. And I just have this slide here to show you the data elements that would normally be collected by SWOG on the left-hand column. So normally you collect patient initials, zip code, and birth date, but Social Security number and address are not required. For the credit linkage we had to do for the study, we had to collect a variety of elements. So I think part of this was just reassuring study participants about privacy. We also had to figure out a process to get data transferred back and forth between SWOG, CRAD, and the credit company. And this diagram just kind of illustrates our process. And here was our accrual timeline. So we ultimately, over the course of 3 years, enrolled a total of 380 patients and 152 caregivers. So 40% of patients had a caregiver participate as well. In the very beginning of this study, accrual was exceedingly slow. There were about 6 months we didn't enroll one patient, and then things picked up very quickly. And I think this speaks to the fact that we, as an oncology community, as researchers, are not really comfortable or familiar necessarily with broaching the concept of financial toxicity, and patients may have been reluctant to share that information. But there was a lot of work done by the patient advocate community and by our study team at these SWOG meetings to really explain the reason and rationale for the study. And really very quickly, things started to pick up, and we actually ended up enrolling quicker than we anticipated. The final study population was, median age was 60. They were mostly white. Only 2% of patients were uninsured. 58% had an income less than or equal to $50,000 annually. And though I don't present that data here today, 92% of patients have complete credit data for us to look at. So we are in the process of looking at those data. Here are our primary results. Major financial hardship was increased cumulatively over time. And at 12 months, 71% of patients had reported major financial hardship, represented by the yellow bar. Because our definition included any form of debt, which many people had. It was the most common component of financial hardship. We did a secondary analysis where we excluded debt from our definition. And when we did this, we saw that still around 45% of people reported major financial hardship. So I told you just a few moments ago that the prior literature had suggested around 20 to 40% of cancer patients experience financial hardship. And our study showed that over 3/4 of insured patients experienced financial hardship. So this is much higher than we previously thought. And I think this is related to the fact that we were prospectively collecting this information in people with advanced cancer. In terms of risk factors, we looked at a number of factors: age, race, marital status, employment status, household income, and really didn't see any significant associations between these factors and our outcome. And I think this is because the outcome was so common. We did, however, in a post-hoc analysis, find that income and assets less than $100,000 were significantly associated with an increased risk of financial hardship. So our takeaways from this study were that 3/4 of patients with metastatic colorectal cancer experienced major financial hardship at 12 months, far higher than we anticipated from prior studies. But more importantly, patients and caregivers were actually willing to participate in research, not interventional, but purely observational research to help us understand the problem of financial toxicity better. So this is clearly an important issue for patients and caregivers, and ultimately really reinforce the fact that we need better solutions to address this problem from both a clinical standpoint and from a policy standpoint. Just circling back to the to credit data. So a few things I want to point out about credit data. So it's obviously a very rich source of detailed financial information. It is highly representative of the American population. So about 70 to 90% of Americans actually have credit histories, including younger and lower income individuals. And the data is very timely. So lenders typically update credit agencies monthly. It may take a little bit longer for adverse financial events to show up in credit records, but that range is usually around 6 months. So with that in mind, we did a study recently published in JCO a couple months ago where we linked at Hutchinson Institute for Cancer Outcomes Research cancer cases from the SEER registry in Washington State with controls identified in the voter registry records to credit data from the same company, TransUnion. And we had about 60,000 cancer cases and 120,000 non-cancer cases in our sample, and they were matched based on age and sex. And we looked at the incidence of adverse financial events in this population. So ranging from severe effects like inability to pay bills, which we defined as third-party collections or charge-offs, all the way to foreclosures and repossessions. And our main finding was that cancer patients had a higher risk of these adverse financial events. And in a logistic regression and adjusting for various factors that might influence the risk of adverse financial effects, we saw a significantly higher risk in cancer patients. And I think the implications of this finding are really that, these adverse financial events on credit reports can have serious and long-lasting consequences on people's financial security and their financial status and their credit worthiness going forward. So potentially long-lasting implications on their lives. But very recently, just in an announcement came out that in July of this year, there will be some changes that may make this issue of medical debt more favorable. So paid medical collections will disappear from the major credit companies' credit reports, which would have previously been on a credit report for 7 years. Unpaid medical collections will not appear on credit reports unless they've been in collections for a year. So as previously, as it stands right now, 6 months. And medical debts less than $500 will no longer appear on credit reports. The issue here is that a lot of people charge medical care on credit cards. So it's sometimes hard to disentangle credit card overdue bills from medical payments. So this applies exclusively to medical collections from hospitals and doctors' offices. But I would say a step in the right direction. So let's move on a little bit to talk about sort of where we go from here. I think we all understand now that financial hardship is a major problem affecting the majority of cancer patients. And when we think about interventions, I think we need to understand what the factors that play into this problem are. I've already shared with you some of the risk factors like age, lower income, minority race, and so forth. Many of these things are actually not modifiable factors necessarily. If we look, though, at potentially factors at the societal or policy level, of course, there are economic downturns, again, not necessarily modifiable. Poor access to affordable health care, potentially modifiable. The ACA is one clear example for a policy intervention that improves access. Underinsurance, and then, of course, drug pricing. At the clinic and patient level, I think there are multiple potentially modifiable factors. So poor financial literacy. Most people don't have a great understanding of how health insurance works and how to really navigate the whole process. A lack of transparency about costs or communication about costs in the clinic, and inconsistent access to patient assistance resources. And there's been multiple studies that have shown that these programs, both through foundations and pharma companies, are underutilized. And then finally, at the provider level, of course, the concept of low value prescribing practices and testing, particularly at the end of life, which we can't always anticipate, but we certainly can have a sense if people are going downhill and where there may be limited value to the interventions that we recommend. And those interventions often do have financial implications. And so we should try and be mindful of those things. But for the purposes of this discussion today, I want to focus on sort of these clinical and patient level potentially modifiable factors here that I list here. And I would like to just introduce this concept of patient navigation, which many of you are familiar with. Patient navigation has been around for a long time. And it's essentially assistance to patients and families to overcome health system barriers and facilitate timely access to medical and psychosocial care throughout the cancer experience. And there have been a number of studies that have shown that patient navigation can decrease ED and hospital use, improve cancer screening uptake, and actually get people on cancer treatment and get them through cancer treatment more effectively. Financial navigation is sort of an offshoot of patient navigation that really focuses on overcoming the financial barriers to care, including some of the things I list here: copayment assistance, insurance enrollment and optimization, and assistance with non-medical costs. And if you are interested in reading more on this topic of financial navigation, we recently published a commentary in JCO just last week on financial navigation and all the sort of nuances and delivery approaches from financial navigation in the clinical setting. And I'm going to touch on just a few of these ideas today. Importantly, I want to emphasize that the financial navigation infrastructure currently as it stands is there's room for improvement. So there have been surveys that the NCORP has done and the Association for Community Cancer Centers that have shown that it is not the majority of cancer centers that currently provide financial counseling in a very robust or proactive way, or that meet with patients proactively to discuss cost of care issues. I think most of the time we would agree that we refer patients and we have resources for patients in our clinics, but it's often done in a reactive way after an issue arises. And, and then added to this, the majority of cancer centers really don't have a good way of providing cost estimates before treatment, both to patients and to providers. So lack of transparency about costs. The NCI also conducted a landscape survey of financial navigation at academic medical centers. And they found, I would say, similar findings that, that there were some financial navigation staff, but really there was room for improvement. And I think the biggest takeaway from all of these studies is that the process is reactive rather than proactive. And so thinking about, how we can move forward with trying to incorporate financial navigation more effectively into oncology care. So there are different potential solutions. One is to train social workers and financial counselors within the clinic to provide this. Can we include technology or apps that can help us with cost estimation? Can we partner with nonprofit financial counseling organizations that are on the ground kind of doing this work already. And I'm going to comment on the third as a segue to discuss the credit trial. So we have been for a number of years working at HiCOR with two organizations, Patient Advocate Foundation and SENSE Consumer Education Training Services. These are both financial counseling navigation organizations. And we've conducted two pilot studies where we enrolled newly diagnosed cancer patients and caregivers in a program where these organizations met with them regularly, proactively, before a financial issue emerged to see if they could mitigate the financial risk of cancer treatment. And essentially what we found in the context of these studies is that patients and families were less stressed financially, and that they were able to provide concrete financial assistance for a variety of things, including out-of-pocket costs for drugs, as well as transportation assistance, and essentially cost of living assistance. So we know that this kind of navigation resulted in concrete benefits for patients. And so that was sort of the impetus for the credit study, or S1912CD, that I hope many of you who are at NCORP sites would consider enrolling your patients on. This study takes patient and spouse dyads with patients have to have a metastatic cancer diagnosis, either metastatic solid tumor or advanced hematologic malignancy. And they're randomized at the dyad level to either an intervention by the organizations I just mentioned, PIF and SENSE, where these organizations would meet with them monthly over the course of 6 months, versus a control condition of financial literacy training. And we would pull credit reports and survey patients and caregivers every few months. Here are the eligibility here. I'm not going to go through this in great detail, but essentially for the purposes of this group here, we're looking for your metastatic melanoma or metastatic skin cancer patients, essentially. The intervention is provided in English or Spanish, and we would enroll a spouse caregiver as long as they are legally married to the patient and filing tax returns as married, filing jointly. So we are really strongly considering changing this eligibility to allow for partners instead of just married spouses. The reason for this was that we wanted to, the reason for this inclusion was to make sure that the financial association between the patient and the caregiver was consistent. But I think that we've had some feedback that that's been a challenge. So we are going to likely amend this requirement going forward. And there are a number of measurements that I list here. The main outcome of the study is household financial hardship as measured in credit data. So can we decrease the risk of household financial hardship? And can we improve a number of secondary outcomes, including quality of life, subjective financial distress, treatment adherence, hospital use, and caregiver burden? And I think that some of the research questions that some of you might be interested in, or other cooperative groups are actually tackling, are, when and how often to engage patients and caregivers. In this study, we're contacting people monthly, shortly after diagnosis, but there might be better strategies. How do we identify people at risk? In this study here, that we're going to be enrolling all comers, regardless of financial risk. There are obviously going to be some people who might benefit more from an intervention like this. What are all the outcomes we should be looking at? I've listed several in the previous slide, but there might be others that are relevant. And can we introduce some intervention around patient and physician decision-making as it relates to cost? So I think I'm out of time here. So I just want to acknowledge the HiCOR team here and collaborators and co-Is at our institution, SWOG, SENSE, and PIF, and funding agencies. Thank you so much for your attention.
Thanks, Vina. For our virtual attendees, please put anything in the chat if you have. I found something interesting on one of your early slides about who's at risk. I thought I saw females are at risk. Can you like unpack that a little bit for us? Is it married females in addition to single females, or how does that?
Yeah, no, so I think that the reason that women are at higher risk is because historically they have not necessarily been the primary income earner. Or actually I should rephrase that. Females are at higher risk because a lot of women are in our studies we found are younger, who are diagnosed with cancers and dependent on work. So the impact on employment is probably more of an indirect cost. Actually, in one of the studies we did, we found that women with thyroid cancer are at the highest risk of financial hardship. Yeah.
Yeah, there's a comment here in the chat that says there's a wage gap as well between male and female earners.
Yeah.
So, medical costs don't have a gender gap in it, but certainly wages do. And, you were talking about colorectal cancer where there is oral therapy and infusional therapy. And that's what we have in melanoma as well. We have a mix between oral and infusional. Is there one type of therapy that has more financial toxicity, or they both can have financial toxicity in different flavors? It often is something we look at when we look at claims data, and sometimes we're surprised to see, well, oral therapies are being utilized more, but they probably come with their own co-insurance type of financial toxicity.
Yeah, I think I don't think that anyone has really shown that what sort of therapy drives financial toxicity to a greater extent. We tend to think more about oral chemotherapies because people are paying for these at the pharmacy. And I do think that oral therapies are probably associated with greater risk of the behavioral financial hardship and the non-adherence piece, sticker shock at the pharmacy window, than IV therapies. But ultimately, this is a multifactorial problem. It's not just the drugs. It's the cost sharing overall. That's true whether you are getting IV or oral therapy. And it's just true across the cancer care continuum with all the other costs related to hospitalizations, clinic visits, et cetera. So I don't think we can really disentangle it, but I think the non-adherence piece is probably a bigger factor with orals.
Makes sense. If you don't see them take it, they're going to take it.
Exactly.
So in the US, we have a healthcare system that obviously pricing needs to be readdressed, all of these issues. In other countries where they have health ministries that really work on cost sharing with the companies, is the financial toxicity exclusive to the US, or is this really a global problem?
I think it's a global problem, and likely because a lot of the issues are not just the treatment costs or not just the direct medical costs. So actually there's a substantial literature in Canada looking at financial hardship. I think what other countries have that we don't are better protections around employment loss and more people, in fact, if not all people, covered by at least some health insurance. So you're not necessarily seeing lack of access to care whatsoever. But yeah, I think that the challenges of a health shock like cancer that sort of unravels the whole family, both emotionally and physically, financially, it's true anywhere.
Yeah, there's no idyllic Mediterranean place that gets it just right, that where cancer doesn't upend your life, that we can go study from, I suppose.
Yeah, I think that definitely you can, the Scandinavian countries might do a little better in terms of, their health system and insurance benefits and cost than we do. And I think Americans are at particularly high risk, but I don't think there's any country that is that people don't face at least some challenge.
Great presentation. Increasingly, we're seeing lower cost healthcare offerings exclude major cancer centers and be targeted, not because those centers cost more, but because the patients who want a cancer center in their policy will cost more, right? The insurance company knows that if somebody says, I only want an insurance company, an insurance plan that will cover MD Anderson, Moffitt Cancer Center, the Hutch, they've already thought about cancer. They have it in their family. They already have it. So it's a great way to screen. I understand there are some efforts to try to minimize or eliminate those kinds of practices, but can you comment on that sort of toxicity where patients have money but not access, or coverage but not access to a full spectrum of cancer care?
Yeah, no, that's absolutely true. And a lot of networks are narrowing. A lot of options for people are narrowing. So, I definitely think that it is the case that during, you might have insurance and you might have a pretty good plan with a lot, with a pretty reasonable deductible, but not the access to the center you want. And so it is absolutely true. You see this all the time during open enrollment. People shift to change where their location of care.
Any other questions from the audience, from our virtual attendees? All right, thank you so much.
Thank you.
Appreciate it.
Thanks so much. Anyone, feel free to email me if you have questions or want to talk further about collaborating.
For the credit study, how would we enroll somebody in the application?
So that study is only open to NCORP sites. So I think if anyone's at an NCORP site, you should be able to activate the study. We have a survey that you have to fill out to activate the study at your site, and then should be able to enroll. Yeah. Thanks so much.
All right, everybody. Well, we will move down the agenda. We're going to make one little adjustment for flights here and actually have Sam Guild, our patient advocate, just give us a few words to put into context what it is we do when we do clinical trials, particularly large ones through SWOG, but even small ones for rare cancer types. So Sam.
Thank you, Sapna. So I will say, if I could just do my little bit of plug regarding financial toxicity, there are other ways that you can actually help this effort. So organizations such as my AIM at Melanoma, we are actively involved in legislation to address this issue. We sign letters, we go to the Capitol, we have regular meetings. And if you know individuals, caregivers, patients who were interested in getting involved, please send them to one of us. We are always looking for stories. They are very powerful in encouraging legislators to pass legislation that will eliminate these types of barriers. So sorry, I had to do that little plug. But on that note, I also wanted to share with you, so thank you for having me. Thank you for accommodating me. But I want to share with you just a quick story about how the work that you're doing goes beyond your clinic. And is actually moving us forward in the space. So I want to give you a quick example of a woman, Tony. She's a grandmother, and in 2015 was diagnosed with stage 4 melanoma. In the next 3 years, she did gamma knife, radiation, immunotherapy, surgeries. She had been given a 6-month prognosis, by the way. And at the end, she decided after the 3 years, she went into a clinical trial, and 6 months later, she was NED. And now she's actually an advocate. She's encouraged, she talks to people about the importance of clinical trials. So she's giving back. She supports other patients. She shares her story. I think she's actually getting involved in legislation. So the work that you're doing doesn't end when your patient leaves. It actually continues and is helping to push it forward. And so your work is important in so many ways. And I want to thank you for letting me to be a part of it. Thank you, guys.
Thank you, Sam. That makes me so happy for her that she got NED so quickly. Usually bodes very well in melanoma. We're going to go on to our active studies and get an update on 3 studies, starting with S2015, then S2000, S1801, and then we'll move on to talk about our closed studies.
All right, well, I'm excited today to talk a little bit about S2015. Make sure I can do this because it activates today. which makes me very excited. So today was a drop dead date for activation. So nothing like cutting it close, but here we are. So it's an exciting trial, and I've spoken about it so many times that I'm sure you're sick of hearing about it. But now that it's active, we can talk about it in maybe a little bit different context. So I wanted to start off with the thank you slide first. And really, it's, as much as I'm excited about this trial opening, it's really because of the tremendous efforts that the SWOG team, as well as the MAST team in Australia, has put into making this collaboration happen. This is an international trial based in Australia. This is the first time we've tried to do a collaboration with this group. There was a lot of details that I was not aware of about computer systems having to communicate with each other and international regulations. So I'm really excited. So a real big shout out to Katrina, Kara, Jim, and Dana from SWOG for really helping me with this effort, and Dr. Corday for shepherding it through the NCI process. So just a little bit of a quick background, the why of the trial, which is we don't actually know from a surgical perspective what the proper margins are for many melanomas. We've done a lot of work over the years to try to define this, but really we're stuck at the point where, particularly for between 1 and 2 millimeters, whether or not a 1 or 2 centimeter margin in the United States is ideal. And then, as you can see, there's heterogeneity across the world on what margin should be for thicker melanomas. And this study really addresses T2B and thicker primary melanomas. There was an earlier version of this trial. This was discussed in our committee years ago, potentially of SWOG participating in the pilot version of this trial. And that had 400 participants. There was one site in the United States that accrued separately from SWOG, Thomas Jefferson University in Philadelphia. And this study wasn't powered to answer the question of what the proper margins are, but rather it was more of a feasibility trial to prove that this concept could work. And some of those subjects are actually enrolled in this trial as well. The larger trial, the trial that we're talking about, internationally will accrue on nearly 3,000 subjects. So it's a very simple schema. It's individuals who are 18 and above, who have T2B and thicker melanomas. There are some stratification criteria, which including age, gender, country, which will perhaps become even more important now that adjuvant therapies differ between different countries for thicker melanomas. And it's really just randomization between a 1 and a 2 centimeter margin of the primary melanoma, and sentinel lymph node biopsy is expected per standard of care. Follow-up is for, it's mandated up to 5 years, but there is an option of following up to 10 years. So these are the objectives. Disease-free survival is a primary endpoint, and you can see the secondary endpoints. I do want to point out that some of these endpoints at this point are not relevant to our trial in the United States. The ones that are relevant are things like local recurrence disease, distant disease-free survival, melanoma-specific survival, overall survival. We do not have a quality of life element in this trial yet. That will hopefully be added in the future. That is an important component of this trial internationally, and we do want to participate, but that is not within the trial right now. And the health economic evaluation is important, as we heard from our earlier presentation, but because of the significant differences internationally, we have not included that at this point. So these are just briefly the eligibility criteria. And again, it's T2B and thicker melanomas. These are primaries that are cutaneous. It's essential that a 2 centimeter margin be feasible. So if you don't think a 2 centimeter margin is feasible, that individual could not participate in this trial. Sentinel lymph node biopsy has to be done. And there can't be other confounding issues with regards to survival to complicate the picture. And follow-up, as I mentioned, is fairly standard follow-up that we do, and it's mandatory up to 5 years. There is that 10-year option, which I alluded to. So with that, thank you again for allowing me to present about this trial. Again, since it activated just today, we don't have any sites yet. There are 6 sites in the United States that are already accruing independently from SWOG. They'll get rolled into the SWOG effort as well. And I'm looking forward to robust participation from within the United States. And I'm happy to answer questions. No chat questions. And if you have questions afterwards, please feel free to stop me as well. Thank you.
Congratulations, Josh. Champagne. Zainab, would you like to do S2000 next?
Thank you. So I'm just going to give a quick update for S2000. This is our brain met study, randomized phase 2 trial looking at combination of encorafenib, binimetinib, and nivo versus ipi-nivo in patients with BRAF-mutant melanoma brain mets. And we've had the study open now for a little over a year. So I think most everyone's familiar with the rationale for the study. Basically that with targeted therapies, we can see high intracranial response rates, but very limited PFS intracranially compared to systemic mets. Whereas with immunotherapy, ipi-nivo, the intracranial response rates and PFS can be quite limited in patients with symptomatic brain metastasis. So our goal with this trial was try to improve outcomes in patients with melanoma brain mets, including and especially those who have symptomatic brain mets. So the study schema, as I previously presented, is fairly straightforward. We have arm A, which is the combination of the BRAF/MEK inhibitor, encorafenib, binimetinib at standard doses with nivo every 4 weeks. Whereas arm B is the standard treatment, that's ipi at 3 mg/kg with nivo, continuing with nivo afterwards. And the study is stratified for whether or not patients have symptomatic disease. And again, we do permit patients who are on corticosteroids, and whether or not they relapsed less than 6 months following any prior neoadjuvant or adjuvant therapy, or more than 6 months. And patients undergo routine imaging, including a 6-week brain MRI, and then every 12 weeks thereafter. Our primary objective is progression-free survival, either intra or extracranial. And then secondary objectives include response rates, including comparing some different intracranial response rates, such as modified RECIST criteria, RANO, BM, and iRANO, and looking at toxicity. We are also collecting some blood tissue and stool samples from patients for any future correlative analyses. So just to emphasize a couple things with eligibility criteria, again, the study does permit patients who are on corticosteroids up to 8 milligrams of dexamethasone a day, and prior local regional therapy, including prior radiation of brain metastasis or surgery, is allowed as long as there is one measurable progressing brain met at least 0.5 centimeters in size. So I just wanted to emphasize that, since I think that's been challenging in terms of accrual for some of the sites in patients who get prior treatment, such as surgery or radiation for brain mets. And patients can start on the study 7 days after finishing radiation. Again, we would want one non-radiated brain met, unless there's progression following radiation. And again, prior surgery is fine as well. And we don't need extracranial diseases, not required. Brain mets only is fine. The trial does permit prior systemic therapy if in the neoadjuvant or adjuvant setting, whether it's anti-PD-1 therapy or BRAF/MEK inhibitor therapy, as long as there wasn't any very severe toxicities to immunotherapy or Encobini that required discontinuation or prolonged courses of steroids. And again, we try to keep the eligibility criteria fairly as unrestricted as possible. And again, some standard correlatives, which are all optional, including collection of EDTA and Streck tubes as well. And the design is basically requiring up to 100 eligible patients with 50 patients per arm. So far, we've enrolled 11 patients just over the past year. So the accrual has been slow, although I think has picked up a little bit within the past few months. So I think, in discussing with some of the sites who have the study open, I think the importance of a multidisciplinary approach is really important, especially oftentimes patients with melanoma brain mets may be seen first by neurosurgeons or radiation oncologists, especially those coming in with symptomatic brain mets, and not necessarily first by medical oncologists. So I think that does present a challenge in terms of accrual, screening for the study if there's a patient who's already had all brain mets potentially treated with, stereotactic radiation, or has, already had surgical resection of all the mets. So one approach we've used at Moffitt is for patients with symptomatic disease, working with the radiation oncologists and neurosurgeons, those lesions that may be in more critical locations or thought to be, need immediate intervention have been treated. But as long as there's one untreated lesion that remains after surgery or radiation, again, the patient remains eligible for the trial. But I think, again, it's that importance of having that discussion and actually notifying the medical oncologists at the time that a patient with a brain met is seen. So even things like, a BRAF mutation testing could be ordered. So again, for sites that have the study open, I would just encourage making sure that neurosurgeons, radiation oncologists, sometimes even inpatient hospitalist teams, where patients with brain mets may be admitted first, that they just be, be aware of the study. We do have currently some other larger cancer centers also in the process of opening the study. So we're hoping with all of that, we'll start to see an uptick in accrual. And again, if any questions about eligibility, anything, feel free to send me an email. Thank you.
Sapna, you need to tell us what the accrual is.
Oh, the accrual is 11. I think I thought I mentioned that, but
You did. Where are these 11 patients being enrolled? Is it all at Moffitt? Or are they?
No. So 4 of 11 are at Moffitt. So are scattered. I think there's one at Michigan and a few community centers, a couple through ECOG. We also have the study open at through ECOG with ECOG Champion and through NRG as well with an NRG Champion.
So Zen, if I wish you all the luck, and I know from deep experience how difficult it is to do these trials, but I am a little bit concerned about this concept of letting the radiation oncologists sort of treat certain lesions and leave an untreated, because A, it's likely to be the smallest one. B, there are issues later on down the road of stereotactic radionecrosis. C, I would worry that patients would not be too keen on that. If the patient had 5 lesions radiated and the rad onc or the med onc or both said, but we're going to leave this other one in your brain, would they, or maybe not? Maybe they would say, well, if I'm going to let 6 of them be unirradiated, I might as well let 1 be unirradiated, while testing the drug. What do you think?
Yeah, it's a great point. With the patients we've enrolled who have had prior stereotactic radiation, it's basically been maybe 1 or 2 larger mets that were in critical areas that the radiation oncologists and neurosurgery felt very strongly needed to be immediately treated. And then there were, a few other smaller mets that were thought, that's okay to, these don't need immediate intervention. So I think when it's clearly explained to the patient and there's not, you don't have the radiation oncologist saying one thing and the medical oncologist saying something else with regards to the role of, radiation and systemic therapy for treating melanoma brain mets, then I think the patients we've enrolled have had a good understanding and have been willing to go along with that and have understood why you could do stereotactic radiation for a larger symptomatic met and then, then proceed on to systemic treatment. All of them also had extracranial disease. So it was also a situation where they knew they were going to need systemic therapy. And the idea of being able to enroll into this trial was appealing since, they had the 50% chance of getting a triplet, encorafenib and Nivo that's not, commercially available. So I think when it was explained that way, they've been willing to enroll. So.
Yeah, this is Takiao from Kaiser Permanente. I was going to say it's probably different from institution to institution. Where I practice, it's even different. We have 23 sites, and even among those, not all radoncs treat brain mets in the same way. But if someone had an issue with an untreated brain met from a radonc standpoint, having the option of treating some as opposed to none is helpful. So I think it's helpful, Kim, just as another perspective to have that, because I think just to your point to always have it be a multidisciplinary discussion, I think is probably best for this trial. Rather than have it be disjointed. Oh, go to your radonc appointment and come back. I think that usually will probably create a situation where then there is ineligibility because something will happen that'll make this protocol not be considered. So that I would say.
And I think it gives time to, obtain BRAF mutation results. Obviously, patients, if it's a new diagnosis of, metastatic melanoma, unfortunately, that result may not be available depending on, the patient's history. So, and we do allow only within 7 days post-radiation, the patient can start on the study. So there's not a huge time delay in patients that do get radiation to then starting on the study treatment. So.
Zainab, just thinking how to help you with enrollment here. So in your 11, how many are in the asymptomatic cohort? How many are symptomatic? Do you know off the top of your head?
I think I'd have to check exactly, but I think it's half and half.
Okay. So because I would think that a lot of these are coming through medical oncology. It's not that people are, early stage melanoma and then symptomatic brain mets. That's not the most common scenario. Maybe more common is they're metastatic, they're on some treatment, and then there's progression in the brain. So we may have to take a straw poll of, people on virtual, who are joining virtually and here, what are you doing for the patients who come through clinic with asymptomatic brain mets or even symptomatic that are coming through, say, medical oncology? And if they are, coming in the door emergency room to neurosurgery, is there any sort of alert to the medical team that could be made so that the neurosurgeon, the radiation team is aware, hey, let's also talk to medical oncology. This is a multidisciplinary case. Maybe there's a stepwise strategy and get them on. Just thinking, we need to figure out how to get you more patients through the medical oncology side.
Yeah, I think with the Moffitt neurosurgery team and radiation oncologists, as we know them well, I've had several conversations and they do notify us to their credit, but obviously, I don't know that that's being done at every site that has to study open.
And you bring up another really key point, which is if somebody has extracranial metastasis, which is going to be a fair amount of these people. Yes, there's CNS only disease, but a fair amount will have extracranial. Being eligible for this trial gives them access to a triplet that they cannot have any guarantee that insurance will pay for. One part of it or the other, or just the whole regimen. And then we're back to this financial toxicity discussion, that patient will, if they want this kind of cool triplet, would end up with some financial toxicity. So, it may be another way we can think about it for our metastatic patients is if there's progression and they have progression in the brain, that this is really offered to them as an opportunity to get a novel triplet. But would they be eligible? So you said prior adjuvant, neoadjuvant PD-1, could they have had PD-1 in the metastatic setting?
The way we have it currently written, no. So it would have had to have been neoadjuvant or adjuvant. So
I wonder if that's holding up anybody's enrollment, that they're finding patients that they're PD-1 treated. And then,
You're already giving up on the best patients by allowing a little bit of steroid, allowing symptomatic patients. I don't think you should lower it.
oh, he wants, and it's on the microphone.
Oh, did somebody else?
No, he wants it on the microphone saying it.
I forgot what I was going to say. Well, yeah, I wouldn't agree with that. Oh, I know what I was going to say. Yeah, it was about advertising. So I am pretty sure that there have been in the history of our field, you know, sort of focused or targeted, to use improperly these words that we use, campaigns to raise the consciousness of either already participating investigators and institutions or those who are not, in order to, because sometimes you just gotta hammer on people to remember stuff that's a low frequency event, like a de novo diagnosed, good performance, you know, low volume, BRAF mutated patient with melanoma. That's like the brain and usually the body. You know, they don't come along every day, as you know. So it might be possible to design something. I don't know whether SWOG would do it for you, or whether Moffitt, but I would definitely try to pursue that.
yeah, I think we had a couple discussions in terms of designing a small flyer or informational flyer just to give to the sites, and also that they could distribute to the radoncs and neurosurgeons as well. Yeah, that's a good
But
idea.
now we really are talking about a niche population, right? We're talking about a PD-1 naive patient
In the metastatic setting.
in the
But
metastatic
I feel
setting.
like
gets it in
more
the
and
brain.
more getting these drugs now in the neoadjuvant and adjuvant.
But their
setting.
first recurrence may not necessarily be in the brain. So then
Right.
they'll get extracranial, they'll get some PD-1 based therapy. And then by virtue of progression in the brain, they won't be eligible. But
they were diagnosed with their first relapse with small volume disease, an asymptomatic cohort, which is the best.
right.
Naturally is a biased outcome, but that's how we got the right.
But I also think, yeah, okay. I mean, you're right. I also don't know if it was just a little different landscape then, because now yeah. Well, let's see. Is there any way to capture if you're screen failing for PD-1 treatment? Just another thing to consider.
I mean, again, I'm open to any suggestions on the eligibility criteria, and I think that's something we can consider if need be to help with the accrual. Thank you.
Okay, we'll move on to our last active study, which is S1801. As you guys know, S1801 is a neoadjuvant study in the NCTN. And just briefly, the schema is pretty straightforward. It's clinically detectable, which means measurable radiographically or clinically apparent, greater than 1 centimeter, stage 3B to 3-4 resectable melanoma. It really requires a multidisciplinary approach too, because there's surgery involved in both of these arms. So you have to ensure that your surgeon is comfortable with their patient being randomized and either having to go first with surgery or go after some neoadjuvant. So it was designed as a 500 patient study, randomized 1-to-1. The top arm is the adjuvant arm where patients would go for surgery and then have 18 doses of flat dosing pembrolizumab every 3 weeks. The bottom arm is the neoadjuvant arm where they would get 3 cycles of neoadjuvant flat dosed pembro. And then ideally between weeks 7 to 10, 7 to 11, I wrote on here 7 to 12, I should just read the slide. They would have surgery, and then they would follow that with 15 cycles of adjuvant pembro flat dosing. And we are allowing adjuvant radiation on this study. S1404, which was a precursor study of adjuvant pembrolizumab versus standard of care, also allowed radiation. And so we also felt that because these were some bulky tumors, many times have extracapsular extension, these patients still were warranted a discussion of adjuvant radiation. So that was allowed at the discretion of the investigator, and we'll do some subgroup sub-study analysis of those patients. I should note that this is one of the only neoadjuvant studies that allows that, because a lot of neoadjuvant studies have said just move on to systemic therapy, even if this was a case where radiation would have been discussed. And we do have correlative blood collection at various time points along the way. The primary endpoint of this study is event-free survival with pathologic response as a secondary. And event-free survival means, relapse, inability to get to surgery, removal for toxicity prior to surgery, et cetera. And so as of a couple of weeks ago, we have over 700 sites open, almost 500 of which are NCORPs, so our community oncology sites. So that's wonderful to see that amount of engagement in something as novel as a neoadjuvant study. And the majority of the enrollment has been through SWOG, but we have really nice engagement across the intergroup as well. And as far as our total enrollment, I should put my glasses back on because I can't even see the screen. But we're at, I left them down there. We're at 326 patients, evenly split between the two arms. And the state of Michigan, wow, the state of Michigan is crushing this study. They have 28 patients between the University of Michigan that have 14 enrolled, and one of the Michigan NCORPs that covers a few sites, they also have 14. So thank you to the state of Michigan, who also sounds like they're enrolling on the brain mets trial, which is good. And then Huntsman, thank you, Dr. Hengstrom. Dr. Hengstrom is a surgical oncologist who's PI of the study. And so it's nice to see that we have kind of a balance of medical and surgical. It doesn't all have to be through medical oncology. Northwestern Ohio State is doing a great job enrollment and enrolling in our runner-ups, our University of Alabama, Birmingham, UAB, Northwell Health, which is an NCORP site in New York, and then MD Anderson has 10 patients enrolled. So we're doing fine as far as enrollment. We're at, as you see, 326. We may not need to go all the way to 500 patients when you have an event-driven study. The study, closes when it hits the number of events needed. And so we may actually be approaching that sooner than 500 patients. So stay tuned for an announcement from CTSU. If we think the study will be closing imminently, there'll be an announcement and you'll have another month or two to get your patients on study. Any questions about S1801? Let me grab the chat here. Oh, great. Yeah. Paul is saying that the NCOR actually has 19 patients enrolled. I should say this enrollment update is accurate as of March 26th. The allocation is from March 3rd. So it's lagging a little bit behind. So yeah, Michigan probably has even more patients. Thank you guys so much. All right, great. Nothing else in the chat. Okay, so we will move on to closed studies. Let me just double check the agenda here that I have. Okay, here we go. So moving on to closed studies, we're going to hear from our first speaker is virtual. Ari Vanderwald from the West Clinic and now Caris is joining us. I see that there's more chats here than I'm seeing here. Does that little bubble?
Yeah, but if you've read them and they haven't, you won't go.
Got it. Okay. Got it. All right. So Ari is joining us virtually today, and he will give us an update on a very exciting trial that we will hear in a few days here at AACR as an oral plenary. The study is S1616, which should be recognized as just as S1801 is the largest neoadjuvant trial in the melanoma space. S1616 will serve to be the first prospective randomized trial of what to do in the post-PD-1 setting. So Ari, if you're there.
I'm here. Am I supposed to share my screen? I don't know exactly how to do that. So I'm going to share screen and we'll see whether it works. Can everybody see it?
Looks good, Ari. It's not, yeah, looks great.
Okay. I unfortunately am not able to give you the full AACR presentation as it still is embargoed, but I will be speaking on Tuesday morning. This study has been floating around SWOG since 2014. It was given a number in 2016, so some of you might not be as familiar with it. This is looking at the combination of ipilimumab or nivolumab plus ipilimumab in patients with metastatic melanoma that have primary resistance to PD-1 inhibitors. The way that we kind of hypothesize that this works is that generally speaking, the CTLA-4 checkpoint keeps white blood cells in the periphery and in the lymph nodes so that they're stuck. And by freeing up the CTLA checkpoint, we're actually allowing the white cells to infiltrate the tumors where they're going to be made available to the PD-L1 antagonists, so that PD-L1 to the PD-1 antagonists, so the PD-1s are actually able to work. From a clinical perspective, we realize that we really don't know what second-line therapy is in metastatic melanoma. We don't know whether or not after PD-1 we should be giving ipilimumab alone or we should be giving ipi plus nivo. We don't know whether or not primary resistance can be reversed with combination therapy or just single agent therapy alone. So that's the reason that we did this study. The primary objective of the study is PFS, looking at patients who didn't respond to anti-PD-1 or anti-PD-L1 agents who were treated with combination therapy with nivo plus ipi versus ipi alone. Secondary objectives included a really important translational medicine objective, which is looking at T-cell infiltration between on-study biopsies of patients who responded to combination therapy as compared to those patients who did not respond to combination therapy. Also, we're looking at objective response rate, overall survival, and toxicity. The way that we did this study was we randomized in a 1-to-3 fashion. This was a very unbalanced randomization on purpose because we wanted to make sure that we had an adequate number of responders to allow for the secondary objective of T-cell infiltration to be adequately assessed. But we also made sure that we had enough power to be able to compare the two arms. So we compared, 25% of the patients got ipilimumab alone at 3 milligrams per kilogram. 75% of the patients got ipi at the same dose and same schedule combined with nivo. And then after 4 doses, went on to get nivo 480 milligrams every 4 weeks. We did tumor assessments every 12 weeks for a year, and then we continued treatment until clinical benefit persisted with overall survival follow-up for 2 years. We also importantly did biopsies both before starting treatment as well as early on study between days 28 and 35, and we collected blood at the same time. Eligibility criteria, most of you would probably imagine that you could guess these, stage 4, unresectable stage 3. What's important is that the patients had to have received anti-PD-1 or anti-PD-L1 agents and had disease progression while on these agents or after stopping therapy, and they can't have received a confirmed or partial, partial or complete response to the anti-PD-1 or PD-L1 agent prior to progression. So these are primary resistant, not secondary resistant. They had to have a performance status of less than 2, had to have measurable disease, can't have gotten prior ipilimumab, although they could have gotten prior combination therapy with PD-1 and something else, although very few patients did. No active CNS mets, but they could have well-treated disease, and no prior malignancies unless they were treated with curative intent. This slide shows a little bit more about kind of where everything happens. So they had biopsies done before starting therapy. Ipi-nivo or ipi by itself was given on day 1 and again on day 21. On day 28 to 35, they had their biopsy and their research blood. Somebody have a question? Okay, I'll keep going then. Then ipi-nivo was given again on day 42 and again on day 63. CT scan was then performed on day 78, and then the patients on the ipi-nivo arm would switch over to nivo. This is the way that the study accrued. It chugged along for quite a while. It took about 3 years to finally accrue, but it did accrue. So Zainab, you should keep plugging at it. You'll eventually get there. And we accrued 94 patients. The last patient was accrued in July of 2020, and 91 eligible patients were treated. The difference between 94 and 91 has to do with patients that were randomized that weren't eligible or patients that were randomized that didn't ultimately get treated. And this was truly a group effort. SWOG and the NCORE sites really did a wonderful job of representing patients from where they were. There were 35 sites across the US that enrolled these 94 patients, and these were across 18 different states. So the results of the study, they've been generated, including early results of the translational medicine piece. I can't share the translational medicine piece today. The results were under embargo until today. The full results are going to be presented at AACR on April 12th. Hopefully we'll see you all there, but being as AACR just lifted their embargo, I can read you the results section if you want from the abstracts that were just released today, despite the fact that I can't present more than this. So as I mentioned, 92 patients were enrolled, 69 to Ipi-Nivo and 23 to Ipi. The median age was 64 and 69 in the two arms respectively. They were about equal numbers, were male and female. 65% of the patients in both arms were performance status of 0. The hazard ratio was 0.63 for a PFS with a statistically significant one-sided p-value of 0.04 favoring Ipi-Nivo. The 6-month PFS estimate was 34% and 13% for Ipi-Nivo and Ipi respectively. The objective response rate was 28% for Ipi-Nivo and 9% for Ipi. And there was no difference in overall survival that was seen. The hazard ratio was 0.94 in favor of Ipi-Nivo, which doesn't really mean in favor of anything, and the p-value was 0.4. AE rates were similar in both arms, and there was 1 treatment-related death in each arm, 1 due to DIC and 1 due to colonic perforation. So that's what I'm able to share in terms of the results. I'm happy to take any questions that you guys might have, and hopefully we'll see you on Tuesday.
Go ahead, Kim.
Okay. So Ari, congratulations. This is Kim. I'm trying to picture the graph that goes along with the graphs that go along with what you were kind enough to read to us, which is very exciting. And the fact that, these immunotherapies, the way the graphs come down for PFS or OS are often a little weird, and they don't really look like chemotherapy or targeted therapy. So I'm just wondering if your results are early enough, I can't remember what your median follow-up was, to hope that maybe there's going to be a later divergence of the curves and maybe the plateaus that you haven't seen yet. Is that something you think might happen, or
you're talking about for overall survival in particular?
Correct. Yes, correct.
I can hypothesize to that, but I can't really give any definitive answers whether I was allowed to or not. The curves, I don't think, we only are following the patients for 2 years, and the last patient is going to finish 2 years of follow-up in June. So I don't think that we followed the patients long enough to be able to see that that divergence ultimately happen, although I also have hopes that over time that would happen.
We have someone else come into the microphone, Ari.
Sure.
All right, it's Vern. Obviously, if a patient got randomized to Ipi, after they progressed on Ipi, they might get immunotherapy again, particularly if they were BRAF wild type. Any ability to look at the cohort who got sequential immunotherapy and compare? Because in that case, it's not truly just the progression-free survival, but the ultimate failure of immunotherapy that is the comparable measurement. Is that something we can look at?
That's a great question. I have a slide for the presentation on subsequent therapies and what each arm got. Believe it or not, it's not as impressive as you might think.
Good tease. Okay, any other questions for Ari? All right, congratulations. We'll have you perhaps give a more disclosed update at our next call.
Great. Thank you guys so much for the opportunity to present.
Okay, moving on to the next virtual presenter. I keep double checking my phone here. It's 1607. This is TVEC and PD1 that will be presented by Siwen. Siwen, were you able to share your screen and do a presentation?
Yeah, so I don't have slides. We don't have clinical information or clinical results to share yet. Everything is still under analysis. I just want to thank our statisticians, Shay Balassi, who is new to the team, and Mike Wu for actively analyzing the data. And also I want to thank the UCLA team, the translational team, including Jia Chen and Katie Campbell and Emilio Medina, who are, and their team as well, who are processing the tissue and doing whole exome sequencing and RNA sequencing. And I just got the slides to do multiplex imaging. So hopefully next time we'll have more information to share.
Great, thank you, Siwen. Okay, and then I think we have in person, our next presenter will be for S1512, Carrie Kendra, who is proving that rare melanoma subsets can be studied in the cooperative group setting. And again, persistence pays off. So take it away, Carrie.
We can put my slides up. So S1512, as you're all aware, is our desmoplastic trial. Desmoplastic melanoma was of interest, in part because of a study led by ZNEP, where they found by retrospective review a high response rate to PD-1-based therapy. We know desmoplastic melanomas are highly prevalent on the head, neck, arm areas, lots of UV damage, high tumor mutational burden, high mutational frequency rate, and with that, potential for high response to therapy. So in this study, we chose to look at two cohorts of patients. One of the cohorts was individuals who had a resectable desmoplastic melanoma, and that could either be a primary disease or it could be recurrent or locally recurrent disease, or even a metastatic site that was potentially resectable. The other arm was an unresectable desmoplastic melanoma, so unresectable disease. In the resectable arm, Pembro was given at a 200 milligram dose every 3 weeks for 3 treatments, and then the patient went to resection. Primary endpoint for these cohort A was pathological complete response rate. Our statistics, we had a single stage design, a pathological complete response rate of 5%. With that, we had more than 4 of 25 responses. We thought it was deemed to be a positive study with an alpha 3.4 and a power of 90%. For the unresectable arm, patients would receive Pembro at 200 milligrams every 3 weeks until progression. The primary endpoint for the unresectable arm was the complete response rate. For that arm, it was a single design, pilot type of trial. If we had more than 3 of 21 responses, then that would warrant further evaluation with an alpha of 8.5 and a power of 82%. This trial is currently under data analysis. We do have some queries pending for some of the different arms, but for the cohort A, the neoadjuvant arm, we do have an abstract that was accepted for oral presentation at ASCO on June 5th. So feel free to stay tuned for that data, as again, I can't present it today. Our data for our second cohort is still under analysis, and we'll do some comparisons between the two as well downstream. So if you do have queries pending, please answer them. If you do have requests for some outside slides, please send them in so we can finish the rest of our analysis. We do have correlative studies that are undergoing with our samples as well. Katie and the UCLA team is leading that, again, with the WES and the RNA-seq. And then we will be looking at further tissue analysis as well. The sites that have accrued, we are greatly appreciative to all of them, especially Moffitt for the high number of patients that they contributed making this trial possible, and all the other sites as well. And a thank you to SWOG and then CTEP and Merck for their assistance enabling this trial to go forward. So data will be presented at ASCO on the neoadjuvant cohort. So we will talk to you more then.
Okay, big congratulations to Carrie on that wonderful news. I think the oral abstracts announcements went out in the last few days. So we'll move on to the next study, which is S1404. S1404, as you guys know, was the largest adjuvant PD-1 study in melanoma. And it reported third, unfortunately, in all the PD-1 adjuvant PD-1 studies. But importantly, it was the first to report overall survival. And so I was just going to take you quickly through the manuscript here. 1404 started out with 1,345 patients and ultimately randomized just over 1,300. If you haven't seen the publication already, it was published in Cancer Discovery, and we were lucky enough to get some accompanying artwork that is unclear if it's abstract or if it's from our data, but nevertheless, this was published, I believe, around November of last year. And so 1,301 patients ultimately ended up getting randomized to therapy. As you can see, the pembrolizumab arm on the left and the standard of care arm on the right. Initially, this was an adjuvant interferon comparator arm, but pretty quickly there was approval of adjuvant ipilimumab. And so we flexed the study to be investigator's choice. And by the end of the study, the majority of patients, 75 to 80%, had received adjuvant ipilimumab on the standard of care arm. And the study had an RFS endpoint with a co-primary endpoint of overall survival, and there was stratification based on PD-L1 expression. So this is our demographics table. It's probably a little bit hard to see on your screens, but not much to say here other than it's fairly well balanced between the standard of care and the pembrolizumab arm. It doesn't seem to be too much discordance or any p-values that seem that they were significant. And here is ultimately the results. What you see on the left is the Kaplan-Meier curve. At the top in panel A, it's the recurrence-free survival with a hazard ratio of 0.76. And on the bottom, you see the Kaplan-Meier for overall survival, a hazard ratio of 0.82 that crosses a confidence interval that crosses 1, not reaching statistical significance. And the study reported overall survival with 57 events reporting. We had 98 events reporting for RFS and 57% for overall survival, which signifies that these patients, do go on to get salvage therapy. We had essentially either an event-driven look at the data or a landmark look. And so we were either going to look if the number of events had been reached for RFS or OS, or 3.5 years after the last patient was randomized. And so once we hit the 3.5-year mark from randomization of the last patient, this is the final cut of the data. And you see that RFS is statistically significant in favor of pembrolizumab, but overall survival is not. And on the right in the forest plot, what you see at the very bottom in all patients is you see that there's a favor, the hazard ratio is in favor of pembrolizumab for all patients. There are subgroups that you can kind of look at, but I wouldn't pay too much weight on some of these subgroups that look significant. Particularly, I think there's a PD-L1 indeterminate that might look significant, or a BRAF unknown. Those numbers are very small, so I wouldn't pay too much attention. But for all patients without subgrouping, the hazard ratio favors pembrolizumab. And so really the conclusion is that S1404 is the largest adjuvant PD-1 trial in melanoma to date, with an RFS that reached statistical significance and a hazard ratio for recurrence or death of 0.76. The hazard ratio for overall survival was 0.82, not statistically significant. We have a quality of life sub-study that will be published soon, and we have correlative studies underway. I think I'd put the same conclusions on the back art. It's nothing new here. So that's it. Are there any questions for 1404? We did spend a good part of this morning's working group session, basically the first hour, if not a little bit longer, just talking about 1404 translational medicine projects. So there's a rich resource here of samples, blood, tissue, surgical outcomes, radiation outcomes in this study. We'll be able to mine this for years, hopefully.
Savna,
Yes, Jeff, go ahead.
I guess there is an adjuvant trial with ipilimumab that does show an overall survival benefit. Now it's much longer follow-up. So is it really that really it could be that this is an active arm, and obviously that's the same as the 238, and they haven't shown survival. So really there may be that the difference is not so much OS and it's really toxicity. And so, but no one would argue that that's worth changing the treatment from IPI to PD-1.
Jeff, when you say that IPI had a survival benefit, are you talking about the IPI versus placebo study?
Yes, yes.
EORTC 18071. So yeah, fair point that there was survival there, but of course that's not two active arms. That's an active arm versus placebo. So
right. No, I agree. But you're also comparing against two active arms here, and maybe the difference will not be OS in any of these studies that have an active arm. And the difference is really going to come down to toxicity, which is a huge difference.
Yeah, that's definitely right. I didn't show you any of the S1404 toxicity data here. It's in the publication that you can see. There were some deaths on adjuvant IPI, as we know. And I think you're right. I think that we don't have a space for adjuvant IPI anymore. I don't know what the role of it is. I've certainly heard Tarhini and the group say maybe it's for people who are adjuvant, recurrent, resected again to NED, and in your sort of second adjuvant life. But I don't know. I don't know if that's really going to be adopted in the field. Toxicity is a real concern. Any other questions?
Sapna, did you guys do a forest plot for OS? The reason that I'm asking is I wonder whether or not you're seeing benefit in patients who got high dose interferon. And your effect, whatever effect that you saw with IPI is actually was overestimated.
Yeah, Ari, we actually did do an OS, a forest plot for OS. It's not part of the main manuscript. If I'm not mistaken, it's part of the supplemental figures. Okay. And if Tony, if you're still hanging on, if you could confirm that we did end up including it in supplemental, because we did look at that. Yeah. Okay. So unfortunately, the next speaker on our agenda, Dr. Alan Al-Ghazi, was unable to attend. So he sends his regrets. So we don't have any new updates on S1320 or S1221. These were both targeted therapy trials for BRAF mutated melanoma. They're undergoing some correlative analysis right now and no new updates. So we really just have one more speaker virtual. It's David Lawson, who's our ECOG liaison, who will present updates on ECOG trials that include SWOG champions, but also those that are being predominantly run by ECOG. Welcome, David. It's good to see you.
Thank you. It's good to be here in New Orleans. I hope it's good. I hope it's good in Seattle as well. I tried to make some slides, but I really literally, Ari said he didn't know how, but he did know how, but I really don't know how to share them. And also I thought if it's okay, I'll just go through some of the studies that we have. And as you mentioned, several of them have SWOG champions. So I was going to ask the SWOG champions to speak to them. First one, I guess, would be EA 6141, which is the Ipi-Nivo with or without GM-CSF. And Dr. Kim, if you're on. No. Well, this trial, pardon? No, this trial unfortunately had to get held up for a while, and accrual has continued to be slow. And I realized I didn't write down what the accrual is. Hello? Do I hear?
You're good, David. You're okay.
Oh, okay. So it wasn't Dr. Kim. I thought maybe it was Dr. Kim talking. I unfortunately didn't write down what the accrual is, and I apologize for that, but I didn't. But it's very slow right now, and this is an excellent trial, and I would like to encourage everyone who sees first-line melanoma patients, which we don't see anymore. I don't know how it is with you all, but particularly I think our community colleagues might be able to help us a lot with this, since that's where I think they're being seen. Second trial would be 6194. Dr. Tarhini, are you on? This is for operable melanomas, and it's a phase 2 trial, and it's looking at pembrolizumab plus CMP-001, which is a TLR receptor, and it's enclosed in a viral-like particle, as it said, and it's designed for intratumoral injection. And accrual to that has gone fairly well. I think it's about 10 or 12, something of that sort, that have been accrued to that out of, no, I'm sorry, it's 5 out of 60 that have been accrued to that one. EA 6191 is a trial that has been discussed for a long time. I know Dr. Ribas has some insights into this as well, but it's a dabrafenib, trametinib with or without hydroxychloroquine trial and it's for advanced BRAF V600E or K mutated. The general hypothesis of this, I should pause for a minute, is Ravi or Janice, either one on?
I don't see them here,
so.
David. No.
Or, no.
I don't see them.
No, okay. Well, at any rate, the hypothesis of this is that the hydroxychloroquine is going to augment autophagy and cause more cell death. Now, these trials have been around for a while, and so we'll see what comes of this. But so far, the accrual is only about 1 patient out of 84 that are designed, that the study is designed to accrue. EA 6192 is Jeff Gibney. I don't think there is a SWOG champion for this one, but it's a biomarker-driven, it's a phase 2 study, and what it's trying to get at is, can we stop our immunotherapy after a year rather than going on for 2 years in select patients? And the main biomarker that he's using is PET scan being negative at a year. This one has accrued 12 out of 150 proposed, and it's not been open all that long. So I would say that accrual is going reasonably well for that.
David, we do have a SWOG champion for that one. That
Oh,
trial
okay.
should have Takeo Trong listed as our SWOG champion. I
Okay.
don't know if there's any additional updates that Takeo has on this. I'm just looking at her right now in the audience to see.
Oh, Takeo, say something.
Let's see. Give her a second to come to the microphone.
No, I apologize. I didn't.
No,
I
David, you're
didn't
okay.
get that.
I actually think we don't have it listed somewhere because in the reports, it's not coming through with the SWOG champion.
Yeah.
So we may need to work with Katrina and Natasha to just make sure we have it listed.
Yeah,
Okay.
I get updates, but you're right, we should put it on the agenda. I was only going to say that I think this is a great study, and if anybody had interest, we should open the study and improve it. It's next on our list for sure.
Discontinuation based on PET results, basically.
PET results, yeah. And at 1 year, which I think many people are doing, but we're not sure, is that enough? You know, so I think that would be really good.
And if it's PET positive, then it's biopsied. If the biopsy reveals no evidence of disease, you could discontinue maybe.
Yeah, and I think it's also David confirmed, but I mean, this is a collaboration with the SITC grant, looking at the biology of who would or wouldn't be a good person to discontinue. So I think, you know, from a basic science standpoint and also a clinical care standpoint, it's a great study.
Question from Kim.
Yes, it's no, I think, I mean, if it's Ipi-Nivo, I think it's the same. So it doesn't have to be PD-1 alone. I think it's with anybody with whom you can.
David, do you have the study there is for any checkpoint treated patients or single agent combination, or it's unclear?
Well, that's what I believe. I don't have it right here with me. I apologize for that, but my understanding it's just getting to a year. That's the important thing.
Yeah, I agree. That's what I thought you did.
Okay, back to you, David.
Okay, we have 6183. Now this trial is a really hard one. It's led by Leslie Fetcher. I don't believe there is a SWOG champion for this, but if there is, I would like to hear from him. But it's a neoadjuvant Inco-Beni study in resectable local regional, like N1B, N1C disease. And what's different about this trial, what's making it hard, is it's looking at the ability of FLT PET, which is thymidine-based PETs, to predict whether people are going to respond or not. And so if your institution doesn't have the ability to do those scans, then, which ours doesn't, and I think lots of others don't as well, then it's not a trial that you can open, but it's a good trial if we get into having more sites.
Has she been able to enroll on this, David? I know this manufacturing of the FLT compound, like you say, has limited. What is the enrollment so far?
It's only 2 people have been enrolled out of 42 that are planned.
Okay.
And I don't know what to say about that. I mean, we have the same problem. We can get the stuff manufactured someplace else, but that's just so laborious that people have not been willing to do it.
Yeah.
But
Kim has a question here. Yeah. Do you remember why Leslie decided FLT was the right tracer to use here instead of traditional FDG?
I cannot give a good answer for that, but I do know that there was lots of discussion about it. So it was not lightly taken.
Yeah.
And but I'm sorry, I can't really give a detailed explanation of why. But it was strongly considered to do something else.
Yeah.
And I mean, the short answer would be everybody thinks the FLT is going to be better, but I'm not sure why that is exactly, or even
sorry to prolong this, David, but is it so? ECA works with Akron, right? So I'm thinking, I wonder if this was a brainchild of somebody at Akron, and if there was some kind of collaboration.
yes, there was quite a lot of discussion with Akron at the time. And yes, yeah, the study originated, I think, in ECOG, but the PET part of it was very heavily influenced by Akron and by our imaging colleagues.
Great. We've got about 5 minutes left, David, if you want to keep going.
Well, Dr. Sue kindly sent me some nice slides, which I guess since I'm not going to be able to show him, I'll just let him, if
He's
would.
on, yeah, he's on the call. And Charles, if you want to do a quick screen share,
Yeah,
please feel free.
6174.
Sure, great, thank you. I'm having some computer difficulties, so I don't know if you guys can hear me okay?
We can hear you.
Okay, great,
Yeah, we can
excellent.
hear you.
And thank you guys so much. Again, thank you to everyone that's been supportive of our trial. So Brian Gaskin and I designed this study together. Can you guys see this?
Yeah, looks good.
Okay, great, excellent. So this is our STAMP trial. So surgically resected Merkel cell carcinoma with adjuvant pembrolizumab. So essentially it's stage 1 to 3. And the study hypothesis is that adjuvant pembro will improve both overall survival and recurrence-free survival. And we stratify by both stage as well as attended radiation. The initial sample size for this phase 3 study was 500, but it's now been able to, we've had some back and forth, and we've now changed the target accrual to 280 patients instead. Currently, we have 202 patients accrued, so we've passed that 200 mark. We just need about a little less than 78 patients remaining, so which will be good. Additionally, recently we have approval with revisions from PACT for some supplementary biomarker assay analyses. So that will also be quite beneficial for this trial too. So I just wanted to thank everybody for accruing to this study. I know it's a very rare tumor that not many see, but we definitely appreciate everyone who's been able to enroll to this. Any questions? Nope. Okay. Thank you.
Thanks, Charles.
Yeah, thanks for that. And at any rate, that's all the ECOG trials that we have actively going at this time.
Okay.
Let me ask
Great.
a question about the Merkel trial, because I think, and it's not such a rare tumor, but the question is, what really is the prognosis of the early stage lesions, and how low should we go in putting a patient on adjuvant therapy in Merkel cell? And overall survival in early stage Merkel cell may not be that great, but Merkel cell specific survival in early stage Merkel cell cancer is actually much better. Most of the deaths are not from Merkel cells. So putting a patient like that on adjuvant therapy is kind of a double whammy. They have other problems that are going to kill them, and now you're giving them some new problems and not necessarily helping them. So how many patients on that trial are in the very early stages, and is that really where the value is? If they're not going to have events, they don't add to the trial.
No, of course, I completely agree. I think most of the events are going to happen in the stage 3s rather than the stage 1 or 2. We do allow for stage 1, basically those that haven't had either a sentinel node or kind of a sufficient with other high-risk features. So we do try to account for that. Again, I do agree. Most of the power of the study is going to be in those that have higher stage disease. One of the things here is that, as you know, it is exceptionally deadly, and there are many patients, even with the early stages, that do have failures. And I think that's part of the worth of looking at adjuvant pembrolizumab, because again, just like you're saying, if it shows not much benefit within those early stage patients, then this should not be part of that care. And again, like I said, we're doing some stratification by this also, and we're trying to account for that. And yes, it isn't as rare as we would like. It'd be better if there were no patients out there at all. but it is still rare enough as a tumor that many studies in the past have not had sufficient accrual. And I think we've been very, very fortunate to have the support of people in the community as well as in many academic centers to accrue to this.
Okay, great. Any final questions from the virtual audience or the live audience here? Okay, if not, I thank you guys so much for attending this hybrid spring meeting. It's been wonderful to see you guys virtually and also in person. We'll see you at the fall meeting in October. Take care, everybody.
Thanks a lot.
And for those who have RSVP'd for dinner, we can meet in the lobby at 6:30. If it's not raining, we can try to walk over. I'll be down there about 6:15 and then we'll start walking around 6:30. So you've got my